Hello, my name is Jeff Taylor, and we're here at the 10th International Workshop on Adverse Drug Reactions in Lipodystrophy and HIV in London. And we're at the end of the second day, and we're taking a moment to speak with two lead researchers on their opinions on what the new areas and changes are in the field. I have with us today Dr. Donald Kotler from St. Luke's Roosevelt in New York City, and Dr. Pablo Tabas of the University of Pennsylvania in Philadelphia. So welcome and thank you. And if you'd like to jump in and kind of talk about where you think the field is going and what the new exciting areas are and any areas you'd like to highlight, take it away.
All right, well, speaking amongst ourselves throughout the last day or two, what's been clear is that this meeting is becoming less and less about lipodystrophy and more about disease complications, disease morbidities, changes that occur in patients who happen to be infected with HIV, who happen to be taking medications. They're both important, whether this is part of a single syndrome or whether these are still disease processes that occur that may be related to underlying disease, that may be related to medication, that may be related to unresolved or incompletely suppressed virus infection, doesn't really matter. People are still going to be made sick. What we had in this meeting was more in the way, I think, of basic science advances and a bit incremental in their intensity, in their benefit, as opposed to any real blockbusters that we had seen in our previous meetings here.
Yeah, I think one of the other themes is that all the studies that have been presented about new drugs show that the new drugs seem to be less toxic than the old drugs. So there was a study comparing raltegravir, which is an integrase inhibitor, with a boosted protease inhibitor, which is lopinavir, and it showed that the use of raltegravir is less associated with insulin resistance, which was a problem of other classes of drugs before. I mean, that's not surprising because one of the reasons to develop new drugs is to prevent the toxic effects of the drugs, and that's one of the criteria that the companies use to select drugs for development. But I mean, it's reassuring to see that the new drug regimen seems to be less toxic and better tolerated than the old drug regimens. And I think the other theme that I think is important is that many of the complications that we thought before that were associated with the treatment of HIV, now we are realizing that are more and more related to HIV itself. So I think the SMART study clearly that was presented and published in the New England Journal a couple of years ago showed that patients with HIV have, even if they don't have therapy, they have a high incidence of what is non-AIDS related events like cardiovascular events, liver problems, renal problems, and those events that sometimes we tended to blame the drugs are really related to HIV. And I think we have seen presentations in this meeting stressing that fact. And I think that's one of the other switches in this meeting. We talk more about HIV and a little bit less about the treatment as cause of toxicity.
So cardiovascular disease continues to be a focus of this conference, and as you mentioned, it's kind of changing somewhat in terms of how it's being viewed. Where do you think we are in terms of looking at cardiovascular disease risk in HIV and how we should approach it?
There were a few interesting presentations related to cardiovascular disease. Perhaps one of the most interesting points that was made really came up in a question and answer period in which Jens Lundgren from Copenhagen was asked if the incidence of symptomatic cardiovascular disease was continuing to increase, and he made the point that both he had made before as well as others have made, in that it appears that perhaps heart disease had peaked a few years ago and may now actually either be level or even decreasing. And this is occurring despite an increase in the amount of, or increase in the duration of exposure to antivirals. And it may well be that as patients and as treaters are becoming more familiar, that we're now starting to deal with other aspects of cardiovascular disease above and beyond drug treatments, such as smoking cessation or treatment of high cholesterol or high triglycerides. I will say, though, that the last oral presentation before we sat down here was a study, in essence, of nagging in the Swiss HIV cohort, in which a computerized reminder of each patient's cardiovascular risk was given to the caregivers to see if that would have any change in outcome, and to the extent that they were able to determine it, it did not. Didn't say whether the patients were doing well or doing poorly, but what they did say is that just reminding the physicians to take cardiovascular disease into account didn't seem to do very much.
I agree with you that it was reassuring that in the DAD cohort, it seems that the incidence of cardiovascular events has peaked and is going down. And I agree that it's a combination of better knowledge from the clinicians and more aggressive management of risk factors, and also probably secondary to the fact that the drugs are also less toxic and less associated with increasing the cardiovascular risk. There was a lot of discussions about inflammation, and it's going back to my initial point that we are learning more and more that HIV is responsible for many of these so-called complications of the treatment of HIV. And so several presentations had to deal with the fact that patients with HIV, if they have ongoing viral replication, they have a significant amount of inflammation, and that inflammation might be pathogenically associated with the development of atherosclerosis.
I guess we can't end a talk about cardiovascular risk and disease without mentioning abacavir, which has emerged in the past year as a very controversial agent due to a couple of studies. Do you think we know anything more now than we did when this data first emerged a few months ago?
I'm very confused about that data. It's data, and data is data, and you better believe the data. There was a full session dedicated to discussion and comments and try to understand why individuals that have recently taken abacavir in the DAD cohort had an increased incidence of cardiovascular events. That data that was presented in retrovirus this year generated a lot of controversy, and it has been confirmed in a probably completely separated cohort of individuals, the individuals that were in the SMART study. So around 2,500 patients that continued to take antiretroviral therapy. They look at only the arm in the SMART study that continued therapy, and sure enough, they saw the same type of signal. So I don't know, I don't have a good explanation of why it's happening. The data suggests that it's a real fact, and it's something to take into account, especially in the patient with high cardiovascular risk at the time of starting or moving to abacavir. Another problem for abacavir is that in the Mexico meeting, the AIDS clinical trial group presented data on ACTG 5202, and initiating antiretroviral therapy with abacavir and lamivudine was compared to tenofovir and emtricitabine. And if you had a high viral load, more than 100,000, abacavir lamivudine combination was less potent than tenofovir and emtricitabine. And this has made, in combination with the increased cardiovascular risk, has made the HIV guidelines move abacavir and lamivudine from a preferred regimen to an alternative regimen. So now, at this time, we only have one preferred regimen. The backbone nucleoside for patients that are starting therapy with HIV should be tenofovir FTC, unless there is a very good reason not to use that backbone.